I'd like to talk about impulsive testing of semicircular canal function in peripheral vestibular disease and the work we've done on this in Sydney in the last 20 years. In order to understand how impulsive testing works, one needs to have some understanding of some very basic principles of vestibular physiology. I'm not going to give a lecture on vestibular physiology itself, but just point out certain aspects that do need to be known if one's going to have some understanding of the results of impulsive testing rather than simply resort to pattern recognition. Need to remember that the adequate stimulus for the semicircular canals is angular acceleration, not angular velocity. In other words, it's not how fast the patient or subject is spinning, but at what acceleration they've got to that speed. They can spin at 60 RPM and not be able to recognize it, but if they stop, they certainly will. Need to remember what the adequate stimulus for the otoliths is. It's again linear acceleration, not linear velocity. So no matter how fast someone's traveling in a car, they won't feel that through their inner ears, but if they put the brakes on, they certainly will. We need to remember that the vestibular system, or the vestibular system as a whole, works in 3 dimensions. And when one measures the vestibular ocular responses, one measures this almost always in the horizontal plane only, and that this is a simplification. Most of the clinical information can be had from horizontal vestibular ocular testing, but one mustn't forget that if the horizontal response disappears or diminishes, it may not be that the magnitude's gone, it's simply converted to a different axis. We need to remember that the vestibular system has cortical, brainstem and spinal projections, and the brainstem has vestibular ocular projections and autonomic projections. For the patient, the cortical, the autonomic and spinal are far more symptomatic than the ocular, but it's the ocular that we measure. Patients complain of vertigo, which is cortical, they complain of nausea, which is autonomic, and they complain of unsteadiness, ataxia, which is spinal. They rarely complain of vestibulo-ocular symptoms unless they have bilateral deficiency with oscillopsia. But what we measure in order to have an assessment of the vestibular system is the ocular responses, because they are so precise and so quantitatively linked to the stimulus. There is such a tight input-output relationship on the vestibulo-ocular reflex as opposed to vestibulo-spinal reflex, that is the vestibulo-ocular we measure, and almost always the horizontal vestibulo-ocular. It's important to remember that the vestibular system has resting activity. This is an absolutely fundamental principle in order to understand impulsive testing. The resting activity leads to bidirectionality. In other words, activity can go down or activity can go up. But because of the resting rate of vestibular neurons, this is always asymmetrical. In other words, the activity can increase a lot more than it can decrease. We'll see that soon in a data slide. The last point to remember is the results of acute unilateral deafferentation. Humans and every animal this is done to has an acute marked vestibular syndrome with nystagmus, ataxia, nausea and vomiting. But although the ear never recovers, the patient always does, and that's not because the ear recovers, but because the brainstem recovers symmetrical activity, and it's invariable through the mechanism of compensation. Now, this is a slide taken from one of the key papers in vestibular physiology from Goldberg et al. On primary superior canal afferents. And what you can see here in the top left is what happens to a primary afferent in a squirrel monkey when it's accelerated at 150 degrees per second squared in the excitatory direction of the neuron and the inhibitory direction of the neuron. The other figures show when the acceleration is reduced. So here we have 60, 300, etc. Look at the data with the highest acceleration, which is only 150 degrees per second squared. I say only because in humans, when they turn their heads, they go at many thousands of degrees per second squared. You can see the resting rate in the squirrel monkey is about 80 impulses per second. When the monkey is accelerated in the on or excited direction of the neuron, it increases to 200. when the monkey is accelerated in the inhibitory direction, it decreases to 0. So you can see straight away that were the monkey to go any faster than that, say 3,000 degrees per second squared, there'd be a much bigger rise in excitation, maybe up to 400, 500, 600, but inhibition cannot go below 0. There is no negative firing rate. And there has to be an inhibitory saturation in a neuron that has a resting rate. And this inhibitory saturation is the key to the Headimpulse test. When the animal or the head accelerates fast enough to reach that inhibitory saturation, any more input in terms of head acceleration will not result in any more output in terms of eye acceleration, and therefore the VOR will be defective, and in a conscious, intact human or animal, the compensatory saccade, which compensates for the deficient VOR, will appear, and in many cases can be observed at the bedside. This is the basis of the Headimpulse test. When we're talking about these different eye movements, we need to distinguish between the dynamics of the vestibular reflex eye movements and the dynamics of smooth pursuit and saccades. Because the way we tell that a movement is, say, a saccade is because it has different dynamics to pursuit and the vestibular reflex. So whereas the latency of the vestibular reflex is 7 milliseconds, latency of smooth pursuit and of saccades may be 120, 150 milliseconds, 10 times greater. The peak velocity of the vestibular reflex may be hundreds and hundreds of degrees per second squared. Pursuit, healthy adults, is about 100. The frequency of the vestibular reflex can be 5, 6, 7, 8 hertz. Pursuit is never more than 1 hertz. The peak velocity of saccades is 3, 4, 5, 600 degrees per second squared, depending on the size of the saccade. We also need to remember that the visual reflexes add or subtract from the vestibular reflex. So if the head is turned with the lights on, with vision on, visual reflexes add to the vestibular reflexes if the subject is fixing on an earth-fixed target. If the subject fixes on a head-fixed target, in that case, the visual will subtract from the vestibular reflex. As far as impulsive testing is concerned, turning the head in the light will have some components of pursuit, but they'll be so late that they're irrelevant. This is one of the reasons impulsive testing works, is because it's irrespective of pursuit. It's much too quick. So just to remind us that there are 4 eye movement systems. One, and only one, that's the saccadic system, will make the eye look from where it's looking now to somewhere else. Only one way to do that. There are 3 eye movement systems that keep the eye looking at where it's looking now, as I'm looking at the camera. The vestibular system will keep the eye looking at target as the subject moves. The pursuit system will keep the eye looking at target as the target moves, and the vergence system will keep the eye looking at target as the target comes closer to the subject. Now this figure from Volker Hen's paper from many years ago shows exactly what we mean by the fact that the signal in the vestibular nerve is exactly the signal we measure in terms of the eye movement. This is a monkey that is being accelerated from 0 degrees per at rest to 40 degrees per second to the right over about 10 seconds, a very slow acceleration, maybe 4 degrees per second squared, and then being stopped after about a minute at about the same rate. This is the eye position response, and one can see the nystagmus. Obviously, the quick phases are in the same direction as the acceleration, and when the monkey stopped, there's the nystagmus in the opposite direction. When this nystagmus is differentiated for velocity, you can see here the slow phase velocity envelope of the nystagmus with the quick phases distinguished and cut off there. You can see that the velocity profile follows the acceleration beginning and then decays with a time constant of about 15-20 seconds, depending on the animal, when the animal now moves at constant velocity. If now one compares it with the activity of the primary horizontal canal afferents, this is actually a vestibular nucleus one, but it'll be same in the horizontal canal. You can see that, in fact, that the neuronal activity closely follows the nystagmus velocity. From this we deduce what we measure as eye velocity is what the neurons of the vestibular reflex are doing. And this is for this reason that we can even think of the eyeballs as being speedometers for the semicircular canals. The speed and direction of the eye movement closely reflects the speed and direction of angular acceleration on the semicircular canals. The eyes are the speedometers for the semicircular canals. This is to show exactly the same result in a human, and just to show that although we can't measure primary efferent activity in a human or vestibular nucleus activity, we can measure eye velocity. Here's the nystagmus envelope to a constant acceleration in a monkey, and here it is in a human, exactly the same. So we can induce from this that in fact what we're measuring eye velocity is vestibular nerve and vestibular nucleus activity. Now, this is to show you again what the key features of the push-pull relationship of the semicircular canals. In other words, when a normal human being with two semicircular canals is rotated to the left, there is activation, increased activity in the left horizontal canal and decreased activity on the right. In this picture, an active neuron is shown in red, an inhibited neuron is shown in an empty blue symbol, and an inhibitory neuron is shown with a negative. Excitation of primary afferents on the side of rotation results in excitation of type 1 neurons in the vestibular nucleus on the same side, which leads to excitation of abducens motor neurons and interneurons on the other side, which causes the eyes to go in the opposite direction. There's also excitation of inhibitory type 2 neurons on the other side, which then inhibit the excitatory type 1 neurons, which feed back to the other side. So this is a push-pull relationship with reciprocal inhibition. And the